We're live.
We're live. Hello to everybody out there. We're going to give everybody a few minutes before and to let people kind of hop on.
Awesome. That was great.
Also, guys, everybody who's in the message board so far, we have a chat. If you look on the side, feel free to post messages or questions throughout the webinar. I will get to them if I'm able while we're live. We also have Justine Boss, our marketing director, who will be kind of checking the chat messages as well. And if we don't get to anything during the webinar itself, we will make sure to respond to you afterwards. And you can always email me, kmiller, like the beer, kmiller at hawkrips.com, and with any questions as well.
Awesome. This is so exciting. I don't really do live things.
It's kind of nerve-wracking. I felt myself sweating last time.
It's a little nerve-wracking. There's a reason, like on my Instagram stories, like I never do live stuff because it feels a little Big Brother and a little creepy.
Yeah, I almost don't know where to look.
Yeah.
Like my camera's up here, and then yours might be over here, or I'd like to look at the screen, but then it looks like I'm looking down.
Yeah. It's strange. And like nothing has changed. I'm still by myself, well, with my wiener dog in my room, and yet all these people with me. It's really creepy. It's kind of creepy, the whole concept.
Oh, look, we have somebody first chiming in. Hi, Laura.
How do I see the chats?
Okay, so look to your... Oh, somebody loves your silver hair, just like I do.
Thank you.
The silver thing is like in now. I don't have enough hair to really do anything with. Although the person at the dollar store, yes, I shop at the dollar store when I need to, calls me rogue, and I think it's because of this.
I love this streak. It's so cool.
Thank you. It's my way of spicing life up. I'm a new mom and I'm married, so
I think it's super spicy. I like it.
Winning.
Winning.
Let's see.
Okay, yeah, so I can't see messages, just so you know.
Okay, so if you're looking at your computer, let me see, this is my right hand, my mustache hand, and look to your right.
Yes.
And you see a little box with 3 dots in it?
Yes.
Click it.
Okay.
Does it pop?
It just says all messages are public. And enable chat, which I've done.
Yes. There you go.
Okay.
So then you might get a message now. I'll show you. Thank you to everyone who's here. We'll start in probably about 1 more minute. We have 25 people signed up, 17 people that have actually joined us. And I know punctuality is important too.
Punctuation is also important.
Yeah, inflection. But yes, we'll give people just maybe another minute just to sign in. All right, I just wrote a message. Do you see it?
I don't.
Justine, moderator, maybe help with that one.
I know. It's okay. You just have to tell me if messages come through, so I can't see anything.
I'm female. I can multitask.
I have a lot of ADD, so if people are typing stuff, I'll be like focused on that, and I'll just stop talking. So it's probably actually for the best.
In fact, right? I told Justine to please help me out with it. She's the moderator. You can't see her in here, but she's watching.
I just see Big Brother. That's what I'm talking about.
Yes. So she's gonna help with the messages as well, because I will do the same thing. I'll just sit here and read. I'm allowed to have caffeine this morning.
Oh, nice.
Yeah, my keto iced coffee.
It took all of my effort to not pour a glass of wine for this. So, but trust me, I thought about it.
Oh no, you can have wine.
I was like, I don't care, but no, I'll hold off.
Oh no, if people who do know you and your LinkedIn posts, they'll expect the wine. And actually, Phil Page.
Find out Wednesday.
You know Phil Page, obviously. He just asked for a good wine recommendation for scallops.
Ooh, for scallops. Oh, you want something? You know what is amazing? It's called Ludi. LE, and then the second word is DIET-ish. I think that's how it is. I'll send you a pic, Phil. It's awesome because it's from the ocean. It's from Oregon. I think it's from Oregon or Northern California, but it's got tons of salinity to it, and it goes awesome with oysters. So.
I love this. See, I was pregnant and now I'm breastfeeding, so I have to like limit still. Yeah, I know. Tell me about it. I love my dog.
I didn't mean to have that reaction. You're like, I was pregnant on breastfeeding. I'm like,
we're off to a great start today.
That was really inappropriate.
That's
it just is because I'm imagining 12 months without wine, which is what made that face. Not
no, honey, it's like 24 months without wine.
Oh my gosh, sorry.
It's even worse. Yeah. So I let myself have it once in a while, like Memorial Day, I'll have some. You know, you have to pump and dump for all of you guys out there listening. Sorry. We'll get started on the real stuff in a minute. But I watch your LinkedIn because I'm like, oh, what's new to try? What should I fill my 1 cup with?
My Wine Down Wednesday. I know, today's Wine Down Wednesday.
Wine Wednesday at the local bar. Yep. Yeah. Honey, we should go there.
Yeah.
All right. Well, I'm gonna get started. I mean, I don't want to take up too much of your time. They're usually about a half an hour, but if we go over it, we go over a few minutes. This isn't like a deadline. This is just comfortable. Hi, Ryan. I see you. Michael. Oh, we have a lot of questions. Okay. So first, let's take 5 minutes for people who don't know you. I can't imagine anybody who doesn't, but for anybody that may not know who you are or what you are, why don't you just take the next few minutes to kind of say hello.
Hi. Yes, I'm Sue Falsone. I am from Buffalo, New York. I'm a physical therapist, athletic trainer, strength coach, sommelier wannabe, and now I can add the title author to my yay!
That's very cool.
Yes, I'm very excited. I'll show you. I actually have a copy, very handy. Bridging the Gap to Performance. It just came out in the last week or two. And so yeah, we can talk more about that too, but I'm really excited.
That'd be great. We actually had somebody pop on that wants to know real quick if it's going to be available in ebook or audiobook as well.
It is. It's definitely an ebook. So you can either go to On Target Publications or on Amazon, and it's in Kindle and it's on an ebook and the whole thing. So definitely.
Are you, for people who have any questions for you, do you want them to contact me and then contact you, or can they contact you directly? What's best?
Either one. People can totally contact me. That's not a problem. I do get behind in emails, as everybody does. Email is such a blessing and a curse, but yeah, people can totally contact me. It's great.
Cool. All right. So we have a first question before we dive into the really cool stuff, the iStim and whatnot. How was your first season in MLB, and how did you work your way into baseball? That is a really good question. I was wondering the same.
Yeah. Well, I was working with Athletes Performance at the time, and this was back in 2008. So, oh my gosh, 10 years ago, which is unbelievable that it's been 10 years of this craziness. But I was working with Athletes Performance, and the Dodgers had approached us to help them with some solutions for their performance and their rehabs. And so it just kind of became, I don't know, my account, for, I guess, a lack of a better word. And it was just sort of a relationship that I managed. And then it grew over time. So what started off as a consulting gig with the team sort of turned into a September call-up, and then it turned into a part-time, and it turned into 120 games. And then I took a year off to sort of go back and focus. Athletes Performance was making me a vice president at the time. So I had to choose in 2011. And I chose Athletes Performance. So I went back to Athletes Performance, and obviously stayed in touch with the Dodgers and stayed in touch with those people. And then they had called at the end of 2011 and said, hey, we want to make you head athletic trainer. And so I did that for a couple of years. So it was really kind of a combination of right place at the right time, a really organically growing relationship. Definitely not something I ever sort of sought out. Like most things in my life, I tend to take a different path. And so just was really open to something new and something different. And it sort of grew into what it did, which was their head athletic trainer for a little bit. So I spent 6 wonderful years with the team, and met some amazing people, had some great experiences, and I'm really grateful for it.
Very cool. So within that story, is that when you came across iStim, or how did you come across that form of treatment as either a PT and or ATC?
Gosh, when I first learned about the utilization of instrument assisted stuff was probably 2000. Let's see, I started working for Athletes Performance in 2001. And I think I met Don Chu in 2002. And he was doing instrument assisted techniques. And he's really the one that introduced me to it. Like, oh my gosh, yeah, 16, 15 years ago. And so, you know, Don is just a huge mentor of mine. He is really one of the people that I look up to. Like, one of my biggest things was I never wanted to choose, right? Like, most places make you choose. Are you an athletic trainer? Are you a physical therapist? Or are you a strength coach? And I don't ever want to choose, like,
because you're all of the above.
Yeah, I'm all of the above, right? And so a lot of jobs, unfortunately, make you choose which one you want to be. And so that's why I loved Athletes Performance, was because Mark Verstegen, who's the owner of it, he never made me choose. He just allowed me to be the professional that I was within the team that I was within. And so Don is really like one of the groundbreaking people who function same thing. I mean, he's the godfather of plyometrics, I dare say. So tons of performance training stuff. He's a physical therapist, athletic trainer. And so he was really someone that I looked up to. So when he started talking to me about instrument assisted stuff, I'm like, I'll look into whatever you tell me to. You know, like, I really respected him and what he was doing as a clinician. So yeah, he's really the one who got me into it.
Very cool. I have a question, or there's a question, Michael. What is the best way you improve internal rotation with iStim? That's very specific.
Yeah. Very specific. I know, right? Well, because we're dealing with throwers, right? A lot of times we need to restore their range of motion. And so, you know, there's so much debate as far as the whole GERD thing, right? And like, what's really causing it? Is it capsular? Is it muscular? Is it retroversion? Like, is this a bony thing that we're not going to change? Do we want to change it? Is it necessary in order to throw a baseball? Right? So there's all of these sort of different theories. And so my biggest thing with restoring internal rotation, especially with a thrower, is always normalizing them back to their baseline. So I do a ton of treatment if they'll let me, right? Sometimes at the level that I work at, they are locked into their pre and post game, and there is no changing that. Yeah. But if they'll let me, to really focus on that stuff post game in order to try to restore. So really with instrument assisted stuff, whether it's pre-game or post-game, you know, ideally we work on that entire posterior chain. I'm someone who's really adamant, obviously, about making sure I address the thoracic spine with it too. So when we're utilizing instrument assisted stuff, definitely making sure I'm hitting thoracic paraspinals, making sure I'm hitting that entire posterior cuff, and then also opening the anterior side too. I think sometimes we think, you know, people are lacking internal rotation, so we have to address only posterior structures. I think it's really important to address the anterior structures, because so many times those things pull us forward that we alter the humeral head in the glenoid. And so all of a sudden that humeral head is sitting forward. Now all of a sudden we don't have great joint in order to restore that range of motion. So I think it's really important that we're addressing both anterior and posterior structures. I think that's where sometimes people get locked up, is they just think, oh, they're lacking internal rotation, let me stretch posteriorly. And that's not really the case. We got to centrate that humeral head.
Very well said. I think coming from like the physical therapy side, I've seen it in outpatient clinics every day, where people will either chase the pain or chase the site, or the site of the dysfunction, rather than going along the kinetic chains. Thomas Myers, the anatomy trains, comes to mind. Treating along those, of course, is going to be a lot more effective.
Yeah, for sure.
So I know you do a lot of dry needling. Now here in California, I can't really speak to any of that because we're not allowed to do some of those really cool things.
Very tumultuous topic.
Yes. Tell me about it. I work for the CPTA, so I see it all the time. Yeah. But can you offer us some insight on, or even demonstrate, that would be really cool, how you use dry needling with iStim in conjunction for anything general, or just give us some kind of insight?
Yeah, absolutely. So oddly enough, I have needles with me everywhere. So needling is really interesting to me. And I definitely utilize it. Oh, and I open the package and it's empty because I've already used it. All right, let me find something else. Let's see.
But your hair looks great, so that's all that matters.
Okay, great. So needling is really interesting. And I mean, I can just needle myself. And I'm not going to use gloves because I'm needling myself. So, but normally, obviously, with patients, I would use gloves. So these are a sarin type needle, and there's tons of different needles out there. But basically, you have this needle in a tube, and then basically what you do is you put the tube on someone, and then you click this little thing, and then you tap the needle in. And so I don't know, maybe you can kind of see the handle on my shirt there. And then it just really depends. I mean, all I'm in right now is the epidural layer. And so when you start to look at the research with needling, there's two different types of needling, superficial needling and deep needling. Superficial needling, you're just in the epidural layer, that's all I'm in, right? This is I don't know how long this needle is. It is a 30 millimeter needle. I maybe am in 2 or 3 millimeters just from the tap. So I'm just in the epidural layer. And so there's plenty of research that shows superficial needling is effective, especially for pain relief in the short term. Deep needling has been shown to have a little bit longer term improvements in patient-reported outcomes, including pain and function. So that's why we like to use the deepest needle we possibly can, or safely can, I should say. But really, just superficial needling can be really effective because we're just in the epidural layer there. And I should not be moving around while I have needles in me. But what we think, one of the reasons we think that it helps is that we're altering the sensory input. And so even just being in that epidural layer with just a couple millimeters, I think one thing that's really important to note is that one thing that's important to note is that oftentimes, like, we spend so much time trying to change people's motor output, when really, if we just change the sensory input, we're going to automatically change the motor output. So right away, by putting a needle in someone, even in the epidural layer, we've totally altered their sensory input, or we're changing or we're stimulating sensory system, which means we can potentially alter their motor output. So that's one reason I like it. And then if you want to go a bit deeper, that's fine. I just got a little twitch on myself, which is not necessary, but certainly can happen. And so I've got my little red box handy as usual. But yeah, so then what you can do is you can utilize the needle in order to stimulate epidural tissue, fascia, muscle, tendon, ligament, periosteal pecking from a bone standpoint. So there's a lot of different structures that we can needle. And so needling is just an important part of my practice because it has such an effect on the nervous system, as well as the biomechanical things that it can affect. And then it works really, really well with all my other treatments. So whether I'm using cupping or instrument assisted or manual therapy or exercise, whatever it may be, it works. It just complements nicely because you're, again, affecting that nervous system, which is the whole point of most of what we do.
So here's that's really cool, because I don't know much about, other than why you would do it. I've never really seen it done. Again, being in California, I go to an acupuncturist if I need something like that. Not unfortunately, I don't mean it that way, but I wish that the physical therapy field and we could do that here. So if you have somebody that, and I know that people are treated on an individual basis, patient-centered treatment. But if you have somebody that's coming in that needs the dry needling, is appropriate for dry needling, and is also appropriate for iStim, how would you, in a very general way, how would you put those treatments together? Is there a specific order that you go in, knowing that you can't move? We're not supposed to move with the needles, obviously. Being a passive recipient from the iStim is probably important. Unless you're doing needles here and iStim here, how would you go about that very generally? Just so if people are interested in how you combine that.
Yeah, absolutely. And that is what really is important to me in our curriculum, in our dry needling curriculum for structure and function, is that our first class, our foundations class, is the motor skill class. That's where you learn how to needle. But then our advanced class, our lumbopelvic hip class, our specialty classes that we have is how do you utilize this modality within everything else that you're doing, right? Because I think it's important to note, no one modality is perfect for everybody, right? Exactly. It's so hard on how we combine these things in order to create best patient outcome measures, best patient outcomes. So the way I have found personally, and we're trying to figure out what instrument assisted does. We're trying to figure out what dry needling does. And so there's really no research on combining these two modalities. So all I can offer is a scientific explanation and foundation for what I do and clinical pearl, right? So for my clinical pearl, based on scientific theory, is that I'm going to always needle first. Because what I find is that when I needle somebody, let's say if I needle someone's, going back to our internal rotation thing, right? If I put a couple needles in somebody's shoulder, if their internal rotation is whatever you want to call it, like we'll say 10 degrees, right? And then I put a few needles in someone and now all of a sudden they have 30 degrees of internal rotation, right? After just putting a couple needles in, leaving it in for a few minutes, taking it out, I've gained 20 degrees of internal rotation. One of two things has happened. I've either used magical needles or it wasn't a biomechanical tissue length issue, right? So
Right.
one of two things, needles are magic, or it wasn't what I thought it was. So when I see those huge changes in range of motion, it was a neurological thing, right? Because all I've done is messed with the nervous system. I got an immediate gigantic change in my range of motion. And now I know I have a nervous system issue that I need to maybe abandon my manual therapy and go right to therapeutic exercise and teach the patient how to utilize this new range of motion. If I put needles in people and they get a few degrees of range of motion, or I've decreased their pain, but we haven't had this huge, gigantic range of motion, okay, great. Now I think on top of this potential neurological issue and pain issue, I also have a biomechanical limitation. And that's where I pull, that's when I then go to my instrument assisted stuff to see if I can improve more blood flow to the area, if I can help work some of the scar or whatever the reason I'm utilizing instrument assisted with. I go to that, right? And so that's how I utilize the two together. Is I tend to needle first, see what happens. If it's a magic result, I need to exercise. I need to move. If it's not a magical result, I've got to address the biomechanical limitation that may be present. Maybe that's a capsular thing. Maybe that's a muscle thing. Maybe that's a fascial thing. That's when I go to my instrument assisted.
If you ever find magical needles, let me know, and I'll move out of California and be trained on these magical needles. I think this could be big.
Absolutely.
Awesome. We have another question. It's another kind of cross intervention question. iStim with cupping. Now, I know you have experience with a lot of different modalities, and we all know, like you said, that modalities aren't a one size fits all. Some people think ultrasound, for example, is a hoax. And other people swear by it and nothing else. Don't touch me, just put the ultrasound on me and let me go. Right. But how do you use cupping with iStim? I've seen them done simultaneously. I've seen them done before and after, like you were describing with the dry needling. What do you find works best in general?
I'm in my home office, so all of these things are like on my floor right now. All right, let's see. So here's what I'm going to do. Hang on, I'll be right back. Okay, and now
your
my
office
dog.
Is I like your chair. Your chair is very pretty.
Oh, thank you very much. And there's my wiener dog down there.
Hello, and you said his name was Richard. Richard the wiener.
Richard, and he has his own Instagram, Richard the wiener dog. All right, I'm going to try to cut myself here, which is going to be a bit difficult. Let me balance.
I'm impressed.
Okay, here we go. All right, so with the cupping, right? So what we do is, I don't know if I'm going to be able to get this off.
I like that one. Mine is not as nice as that.
Thank you. We're going to give this one more shot here. Okay, so right as I kind of do this whole cupping thing, what I can do, I've got 3 different techniques that I do, but the way I combine it with instrument assisted, you can do one of 2 things. Okay, it's not going to necessarily work, but you guys could see how it was lifting the tissue up, right? And so there's a lot of different theories, which could be a whole webinar in and of itself on cupping, on why cupping works and how the different techniques that I use cupping with work. But as it relates to instrument assisted, I'm going to offer one theory. So you guys could see, right, as I have the cup on me, how it's lifting the tissue up, right, versus, let me see. Okay, I've got my new favorite toy, my
HT Pro. Yeah, I took that on my honeymoon to Europe with me.
Seriously, because I travel, my practice is on the road, so it's really tough for me to carry a full set all the time. So I am loving this little guy because he comes with me everywhere, and it offers me a lot of different things. So, but anyway, so as I'm using this tool, right? So now as I'm going, we see now I'm compressing the tissue, right? So those are the 2 different things. This lifts the tissue. This compresses the tissue. Is it better or worse? I don't know. And there's not a research study to tell us if it's better or worse. But what I do think is it's different. And so when we begin to look at principles of periodization, right? The body likes periodization. And so whether we're talking about microcycles, macrocycles, mesocycles, in-season, off-season, upper body, lower body, pushing, pulling, our diet, right? We vary everything. The body responds to variability. If you introduce the exact same stimulus into the body all the time, it eventually stops adapting. Mm-hmm. And so when we begin to think about our manual therapy, right? Like I can kill an athlete with a foam roll, right? Like, hey, great to see you today. Grab a foam roll. Oh, you just came off the field? Awesome. Grab a foam roll. Oh, it's an off day? We're going to foam roll. Right. And then like, if I want to get really crazy, I'll schedule a massage for them, or I'll use a massage stick, or I'll use instrument assisted stuff, right? It's all compressive. Mm-hmm. And so what cupping does for the first time gives us something that is decompressive. And so for me, I use these tools to periodize my soft tissue. Maybe Monday I do cupping. Tuesday I'll do instrument assisted. Wednesday I do the magical art of leaving them alone, which I think in sports medicine we can way overtreat our athletes and our patients because they're with us 12 hours a day at times. And then again, Thursday, maybe I cup. Friday, maybe I instrument assist. Again, Saturday, maybe I leave them alone. Sunday, they get in the pool and I let them do more pool work, right? And so those are sort of my ideal things. So the way, like, I think you can use these two things at the same time. So I know people who like put a cup on someone and then they will, I don't know how to do this, but then they will like, you know what I mean? Like put the cup on someone and then like work it away and then move the cup to a different spot and then work away from it. And I think that's cool to sort of combine the two modalities together. What it really does for you, I'm not exactly sure. But for me, in my personal practice, whether you discard all the circulatory theories and all of the theories about what decompression is or changes in tissue stiffness, right? There's tons of theories out there as far as what cupping does. If the only way you use cupping is to sort of periodize your instrument assisted work, I think that's a really cool way to combine the two modalities. So that's,
I have never even, like, I'm mind blown because I've never even thought of obviously I've never worked to your level with athletes, but I periodization, we're all pretty familiar with that. I've never even thought about applying that to soft tissue work. Like that's a really, really cool concept.
Yeah. That's how I've been using it. I've been getting some really, really good results. So that way I'm just not always doing the same thing, right? I don't do anything else with my athletes every single day, right? I don't do the same exercises. I don't do the same exact manual therapy, but yet we'll always do the same soft tissue. So for me, I've really been conscious of trying to do these different stimuluses because I think the body reacts better that way.
Well, yeah, and I mean, science shows that that's how the body reacts and adapts. Why not apply it to soft tissue work?
Right.
It's kind of, why hasn't that been analyzed before?
I know, right?
Very, very cool. We have a couple other questions that came in. Try to blow through them. I know we're kind of nearing towards the scheduled end of the webinar. Let's see. I keep
double checking on my dog to make sure he's chewing his bone.
What's up, Richard? My poor babies are in the garage. They last year. I keep saying last year. Last week they made a lot of noise. They're very large lab rescues. Yeah. Do you ever do? Let's see. Can you do dry needling in combination with e-stim? When and why? Okay, this is a very loaded question, Sean. And also we have a question about wine with Big Macs for Frank.
Ooh, okay.
Whichever question you want to answer first.
All right. Well, wine with a Big Mac, you're going to want like a good, like, I know that, right? Like, I'm such a wino. You want something big and bold and peppery.
Yes.
So to me, like a really nice Syrah or a really great earthy cab goes really well with an amazing hamburger or cheeseburger. So that would be my recommendation for that. And I'm learning wine. So yeah, that's definitely an area of study right now. So hopefully I'm giving some good recommendations, but those are sort of what I'm liking with those things right now.
Yeah, I would think something red, obviously, with the burger.
Yeah, and something peppery to sort of bring out the smokiness of the meat. So yeah, I would go with like a nice Syrah.
There you go, Frank.
Mike is literally barking at himself in the mirror. Can you see him?
That's fantastic.
He's playing with himself in the mirror. It's so funny.
I wish, I wish I could entertain myself like that as well.
I know. He's
the dog's life. So we'll take
needling and e-stim. Yep, needling and e-stim you definitely can combine. So we have, I don't know where my little e-stim unit is right now, but basically you get these little alligator clips and you attach it onto the needle. And so what that does is it makes the electrical stimulation transmit right to where your needle is. So it's super cool. So there's a couple things with this. Number one is we no longer have to overcome skin impedance, which means your electricity goes exactly where your needle is. So this whole let me grab surface electrodes and put them further apart or closer together and see if I can estimate. No, if I want to get down to the hamstring to where the scar tissue is, right, I can take that needle and go, because no matter how hard I press into the tissue, I always have to get over the tissue that's on top of it, right? Mm-hmm. Whereas with the needle, boom, I go right down to where the scar is, where I want to be. I attach my e-stim to it. Now my e-stim goes directly there. I don't have to overcome skin impedance. I know exactly where the electricity is going. So I can utilize the principles of mechanotransduction to help allow the body to convert the electrical energy into a mechanical stimulus into a chemical energy to change what's happening at the tissue level. So that's number one there. Number two, it can help from a pain standpoint. So there's a ton of research on the use of e-stim with needles and how it can help stimulate the endogenous opioid system. And so I'm a part of a group called Safer Pain Relief, which you can look that up at saferpainrelief.org. And so for us, it's all about how can we try to intervene with different types of alternative safer pain reliefs, right? Because obviously the opioid issue is large in this country, right? And we're trying to figure out how can we prevent people from getting into this chronic pain state. And because once they're in a chronic pain state, it's really, really difficult, right? That's why some of our other modalities like biofreeze or kinesiology tape don't always work on people with chronic pain because they're processing this thing so differently. So the things like gate theory and conditioned pain modulation theory, like those things don't work on people who are in chronic pain, right? You have to tap into their opioid system, which is why opioid works really, really well for people who are in these chronic pain states. And so research is really showing us that when we attach e-stim to the needle, we can tap into the endogenous opioid system and the serotoninogenic descending pain pathways, and really, really deal with pain at a really, really cool level.
Oh, now I'm just jealous. I need to get out of California. Not only is it expensive in here, I can't do crap.
I know. It's a pretty cool modality. And again, like anything, right? One modality is not for everybody. Yeah. And it's the way you combine it with your manual therapy and your instrument assisted and your exercise and your tape and your posture, right? And all of these other things. Like there's no one modality for everybody, but it really is. It can be really powerful when you begin combining these things.
Oh yeah, combination therapy is great. I mean, when I first started doing combination therapy, it was two modalities. It was the typical ultrasound and e-stim. And
my dog is crying, and I have to just let him out.
It's okay. We're
in my office anymore.
I could seriously talk to you forever. I'm looking at this thing and it's 1:30. But anyways, combination therapy is fantastic. I've used. We have a topic that we'll talk about sometime later, but Tecra and the iStim or iStim with eStim, if that makes sense.
Yeah.
I've seen amazing results with that.
I haven't tapped into that. It's
awesome
to me as well. Yeah, that's super interesting.
It's definitely a cool concept. I tried it on myself before anything because I was too nervous to put it on a patient first. And because I have a stim unit here, a little, TENS unit, but for any kind of injuries that I've had, I mean, I've had surgeries up the wazoo on my knees, on my hips. I have labral tears in my hips right now. And it really, even just for the pain relief, not the musculoskeletal dysfunction.
Yep.
Very, very effective.
Yep.
We have 2 questions and maybe hopefully we can kind of combine them into one as we wrap up. Thank you guys for all listening to our banter, by the way.
So much. This is my first live webinar.
Let's do it again. This is fun.
Oh, it's fun.
Let's see. What is your advice for PTs who want to learn more about coaching techniques and a best way to bridge the gap?
Ooh, oh my gosh, you can totally buy my book.
I recommend it. I was on the waiting list, but I didn't get a notification that it was out, so I'm going to buy it today.
Oh no, yes, it is. It's out.
Perfect.
Yeah, it's such a big topic, right? And so next week I'm doing a webinar, my time, because it's such a huge topic, right? Like, I think for me as a physical therapist, when I started working at Athletes Performance, the thing I learned very quickly was that the more I hung out with strength coaches, the better clinician I became, right? I think sometimes we as clinicians can kind of think like, oh, well, we maybe have some of the most quote unquote formal education in the room. Well, that doesn't mean you understand performance, right? And so when I first started working in the performance realm, I was like, well, they can do 3 sets of 10 of a step up. They're good to go. They're discharged from therapy. Okay, well, that doesn't mean that they can stand on the offensive line and hit another human who's 300 pounds, right? Like that doesn't equate, right? So what I really learned in those early days working with athletes performance was truly bridging that gap from rehab to performance. Like I had to understand concepts like acceleration, absolute speed, multi-directional movement, what those things meant, what foundationally did the athlete need from a joint standpoint, and then how could I build on top of that? And then I had to get out of my comfort zone of 3 sets of 10, right? I love 3 sets of 10. That's how an athlete moves, right?
Yeah.
I had to learn how to load and coach, because that's another thing I think as a clinician, I didn't really understand. How do you coach 6 sets of 1? Right? Like you need to understand how to coach power, and you need to how to understand how to load and manipulate variables like speed. And so that's the type of stuff that I learned from hanging out with the strength coaches. And as soon as I started paying attention to what they were doing, I became a way better clinician and bridged the gap between rehab and performance way better. And so, I mean, that's what I built my career off of, really, is sort of living in that space. And that's why I'm so excited about the book, right? It was 2 years of insanity. And so it's so good to be out. And it's just the beginning, right? Like there's going to be a lot of education that comes with it, because I think clinicians and strength coaches alike are craving for that, right? I think that clinicians are looking to understand the performance realm, and strength coaches are having injured people walk into their gyms because their insurance is running out. And so we're just living in this day and age where we don't have to practice outside of our scope, but we have to be able to communicate. We have to be able to help our patient in their best interest, right? We've got to leave our letters at the door.
Yeah, and insurance, I mean, don't even get me started on insurance.
I know, right? It's a whole other
they just, they think, meeting that minimum, that range of motion minimum is the same as function, is the same as performance, and it's really not. So taking all of those concepts into consideration when you're treating a patient, I mean, is really, really important. So I'm glad that you guys kind of are going after that, and I'm excited to get the book. I didn't get a notification. I was so upset. We have one more. We'll do one more question. Can you buy the? Well, this isn't a. Can you buy the book on Amazon? That's a quick question. Yes. Sean, yes, you can. Yeah. So one last question.
If you don't like it, don't leave a review. But if you like it, then leave a review.
We'll remove it if you don't like it.
No, I will make constructive criticism as well.
It's very important, yes. Last one, guys, and then we're going to sign off. Thank you guys for staying on late. Very much appreciate your time, and we'll get Sue back. I know she's a very busy woman, but I'd love to get you back sometime so we can just talk more about anything and everything.
Yeah, awesome.
What are your thoughts on anecdotal evidence, such as your variation of soft tissue treatment on a day-to-day basis versus what research might say about how frequently you use soft tissue mobilization, ISTIM or other? Yeah. That's loaded. So
no, I think that's a great question. I love that question, right? And I think that it like just brings me to the topic of evidence-based practice in general. I think what we've done is we have taken the concept of evidence-based practice and equated it to, I need to have a research study that tells me what to do. And that was never the point of evidence-based practice. When you really look at the root of evidence-based practice and what it is equal to the best available research, clinician experience, and patient values. And all 3 of those things are equal, right? And in the center where those 3 things meet, best available evidence, best or clinician experience, and patient values, in the center is evidence-based practice. And we have mistakenly taken that to mean if there's not a research study that shows what I'm going to do, then you're not practicing evidence-based medicine. And that's false. So we have to remember the research is 1/3 of what evidence-based practice is. So my personal experience, right? I've been a clinician for 22 years. That means something in evidence-based practice, right? And so, my N of 1, right? If I do a technique and then my athlete at the end of the night bypasses the physician and doesn't take an Ambien tonight to go to bed, that's an N of awesome 1, right? And I'll take it. If that's one athlete who ends up skipping his Ambien dose because of the recovery techniques that we did that day, like for me, that's huge. So I think we have to look at the evidence. I think it's important to note for most things at this stage, you can find a research study that supports your opinion, whatever it may be. Isn't that convenient? Right? And so we can throw back research studies to support our opinions all day long.
Back and forth.
So we have very little evidence. We have very little proof for most things. And so we have to just keep that in mind. And we have to look at the evidence. We have to look at the research in order to guide us. But we have to remember our experiences and our patient values are just as important in the evidence-based practice model.
Very, very, very cool. I'm stoked. I literally could keep talking to you, but I know that we're now 40 minutes in. So I'll say it a third, fourth, fifth time, however many times I've said it, to all of you guys. Thank you so much for your questions.
Yeah, thanks, guys.
And Michael, yeah, no problem for squeezing questions in. We would love to answer every single person's question. So if you have any other questions, concerns, again, you can email me. You can contact Sue. We posted your LinkedIn LinkedIn link on here so people can follow you. And we will be sure to get you back on here.
That'd be great. And if people I can follow the hashtag for a while too. Is it HawkTalk Live?
Justine, are you still here?
So if people post questions and use the hashtag, I can kind of follow the hashtag and answer stuff on Twitter or whatever.
Yes, awesome. I'll have Justine post that in here, the hashtag, and I'll send it to you as well. For those of you who are still in here, if you do share this webinar and you hashtag it with the information on the slides that will pop up in just a second, we'll send you a shirt. We're glad that you guys joined us, and I'm wearing one example right now of the shirt. I'm just short as hell, so you can't see anything. I'm sitting on a pillow to get this high in the chair. So
that's awesome.
Yeah. But we're also going to pick. Hey, there we go. We're also going to pick a winner from whoever's still on with us. You'll get a full 25% off any purchase, any tool of your choice. So
wow, awesome.
Stay tuned for that. We'll be doing different giveaways each week. And we're just so glad that you guys are joining us on this little Hawk Grips Live journey of ours. And Sue, thank you so much again for joining us. I'm gonna let you and Richard have some time together so you can grab that glass of wine.
Thank you. I know it is almost 2:00. It's time for wine.
5 o'clock somewhere. I'm a parrot head, so I fully believe that.
Absolutely. It's East Coast happy hour.
Yes, it is. All right, guys. It's been awesome. Thank you so much.
Thank you so much, guys. I appreciate it.
Signing off.